Today we will discuss about jaundice. Jaundice, also referred as icterus. So, in this case, there is yellowish discoloration of skin, sclera, conjunctiva, mucous membrane because of increase in the bilirubin concentration. Here are the normal values about total bilirubin, direct and indirect bilirubin. Okay. So in jaundice, the serum bilirubin levels, these are above 2 milligram per deciliter. One very important reasoning based question lies here. Why sclera is the first site where jaundice is clinically detected? I'll answer all the reasoning based question in the last presentation. Here is about the metabolism of bilirubin, or we can say pathophysiology of jaundice. As you can see in the slide, senescent RBCs, they release hemoglobin and there is formation of biliverdin. Hemoglobin, it will be broken down into heme and globin part, okay? And heme, it is converted into green color compound, biliverdin, that will form unconjugated bilirubin. It is bound to protein, albumin. We had discussed this thing in the plasma protein presentation slide. Okay. Now, next stage is conjugation of bilirubin, and this conjugation, it takes place inside the liver. Okay. Inside the liver, the bilirubin, it gets conjugated with UDP glucuronic acid with the help of enzyme glucuronyl transferase that is located in the hepatic microsomes, leading to the formation of water soluble bilirubin, and it will be excreted in the duodenum and bile. Next, there is excretion of bilirubin inside the intestine. As you can see here, the bacteria present there, they will deconjugate bilirubin and it will be converted into urobilinogen. Almost 80 to 90% of this urobilinogen, it will be oxidized by the intestinal flora to stercobilin and excreted in feces. Now this stercobilin, it is responsible for the brown color of feces, and around 10 to 20% of urobilinogen, as you can see here, it will be reabsorbed via portal circulation and carried to the liver, where some of it is recycled for the formation of bile, and a very small percentage, as you can see in this slide, reaches kidneys, where it is oxidized to urobilin and excreted in urine. Okay. Now about Van den Berg reaction. Okay. There is an agent which is called as diazo reagent, composed of sulfanilic acid, HCl and sodium nitrite. When this compound is added to conjugated bilirubin, within 30 seconds we will get purple or reddish brown color. That means there is presence of direct positive reaction. But when the same compound, it is added to the unconjugated bilirubin, initially we won't get any color. But after the addition of alcohol, there is presence of reddish brown color. So this type of reaction, it is called as indirect positive reaction. Okay. This Van den Berg reaction, it will be very important in the classification of jaundice, or we can say discussing about the types of jaundice. Okay, we'll discuss all these types here. So first type of jaundice is pre-hepatic. Okay, the changes might have occurred before the entry of unconjugated bilirubin into the liver. So it is seen in case of excessive hemolysis of RBCs. So we can say that the excretory function of liver is not affected here. But RBCs are so rapidly hemolyzed that liver cells can't excrete the bilirubin as it is formed, resulting in increased levels of unconjugated bilirubin. You can see here, unconjugated bilirubin is in excess. So there are some names of this prehepatic jaundice. It can be asked like hemolytic jaundice, another name is acholiuric jaundice. About Van den Berg reaction, it is indirect positive because there is excess of only unconjugated bilirubin, not the conjugated one. Feces are dark brown because there is more urine, urobilinogen. Okay, in this case. Done. Second type is hepatic jaundice. This type of jaundice occurs when there is damage to the hepatocytes or there is some infection inside the liver. Okay, so there is increase in both conjugated and unconjugated bilirubin. So we can say Van den Berg reaction is biphasic. Unconjugated shows indirect positive, conjugated direct positive. Here both are raised, so it is biphasic. Urine urobilinogen, it will be reduced. Stools, these are of pale color. Okay, pale stool is there. Previously they were, in case of prehepatic jaundice, stools were of, you can see here, dark brown color. Here are pale colored stool. Fecal fat, it is increased. Urine, it is of deep yellow color. Why deep yellow color? Because there is excretion of conjugated bilirubin in urine that imparts deep yellow color. Okay, liver function tests are altered because there is damage to the hepatocytes. Last one is here, post-hepatic jaundice. In this case, there is obstruction in the bile duct or there can be blockage in the intercellular biliary canaliculi. So the rate of formation of bilirubin is okay, it is normal, but the bilirubin that is formed, it cannot pass from blood into the intestine. Okay, so there is no urobilinogen which is absorbed into the blood and none of it is excreted by the kidneys. Okay, so the urine urobilinogen, it is absent. Stools are clay colored due to lack of stercobilin. Okay, fecal fat is increased, urine is deep yellow in color. Van den Berg reaction, it is positive. Okay, conjugated bilirubin is in excess. It has already been conjugated inside the liver, so it is positive, direct positive. So all these types, they were pathological jaundice, we can say. Apart from these, there is presence of physiological jaundice also. Also another name is neonatal jaundice. So this type of jaundice, it appears within 2 to 3 or 5 days of birth and disappears in 2 weeks or 14 days. It can occur because of excessive RBC production in first few days after birth, resulting in increase in the serum bilirubin levels, or there can be hepatic immaturity during the first week of life. Okay, because before the birth of the baby, bilirubin, it is mostly removed via placenta and to a lesser extent by the liver, but immediately after birth, liver has to remove all the bilirubin, and if there is hepatic immaturity, it can result into physiological jaundice. About the management part, management includes prevention as well as treatment. So as far as neonatal jaundice is concerned, we can give phenobarbital. It is hepatic microsomal inducer. It can be given to the pregnant mothers, which increases glucuronide transferase activity inside the liver. For the treatment part, we can give phototherapy. The skin is exposed to white light and that can cause photoisomerization of bilirubin to water-soluble lumirubin, which can be excreted in the bile without conjugation. Blood transfusion, it can also be helpful. Thank you very much. In the next presentation, we will talk about white blood cells.